We are live now. Good evening, esteemed faculty members and all the delegates. Thank you for joining. This is Sahiti on behalf of Shield Connect, welcoming you all for today's webinar, a dynamic dialogue on obstetrics, and the topic is liver disorders in pregnancy. Organized by Foxy Society Chennai and A4 Hospitals and Fertility Center Chennai. It's my privilege to introduce the moderator of today's webinar, Dr. K. Balakumari ma'am. Ma'am has done MD and DGO and is head of obstetrics units at A4 hospitals. Ma'am has received the gold medalist from Stanley Medical College, a devoted obstetrician and gynecologist, a passionate teacher, mentor, and an advocate for women's health. Ma'am is currently the chairperson of Foxy and executive member of Foxy. I welcome you, ma'am, and I hand over the session to you.
Yeah, can you put this next slide, please?
Sure, ma'am.
A very good evening to all of you. Thank you, Sahiti, for introducing me, and welcome you all, the speaker, Dr. Uma Lakshmi, Dr. Sudha, my co-moderator, and all the other participants for an interesting discussion on liver disorders in pregnancy. I'd like to introduce Dr. Sudha, my friend now. She has become a part of the very nice, good team of A4 Velachery now. And of course, we are part of the general A4 all over. And she has done her she is an MRCOG and FRCOG. She has been a good teacher in her center in Oman, and she has joined us. She has taken over the responsibility of developing protocols and doing drills and all those things. A very soft-spoken, but a very knowledgeable friend of mine. Next slide, please. Dr. Uma Lakshmi, she is a young gastroenterologist from Chennai. She did her MBBS undergraduation in Calicut Medical College and post-graduation from Kilpak Medical College, and the post MD, DM in medical gastroenterology also at Kilpak Medical College. She has been working at Prashant Hospital for 4 years from 2015 to 19, and after that at present in Dr. Mehta's hospital. Dr. Uma Lakshmi, welcome, and we are very eager to listen to you. We would like you to discuss more about the practical aspects, because if we are going to have any liver problems, you are always going to refer to a gastroenterologist. But main thing that we want to learn is like how to identify problems beforehand, when to refer, and when all should you suspect liver disorders, when we generally obstetricians, where we tend to miss. So I would like you to highlight those points, and welcome. The stage is yours now. Please take over.
Thank you, madam. Thank you so much. I hope I'm audible and visible also, and my screen is also visible.
Yes, you are.
Okay, thank you. Thank you, ma'am, for that introduction. And for the next couple of minutes, maybe we'll have a small discussion on pregnancy and liver diseases in specific. So what are the physiological changes in pregnancy? First and foremost, your cardiac output, that itself increases by about 40%, circulating plasma volume by 30%. So this begins at around by the 30th week itself, and it can go even up to 50% until delivery or until confinement. There's a decrease in the peripheral vascular resistance. Okay, and this is actually termed as a hyperdynamic circulation. There's an increase in the body water by 20%, which makes it more hemodilute. And that is why you have the physiological anemia of pregnancy, you have physiological hypoproteinemia of pregnancy, because there's an increase in this as well. It's only a relative condition. So, however, the liver blood flow, which is maintained by the portal vein as well as the hepatic artery, predominantly by the portal vein, remains constant. Histology of the liver is also usually normal, and there is no need for doing a liver biopsy unless we have any compelling indication. So one thing what we see in pregnancy, there's an increased estrogen. So because there is increased estrogen, there is an increased vasodilatation, and the insignificant varices also become sometimes significant, but they do not, however, bleed. So even if you have esophageal varices, it's only in the second or third trimester, sometimes they can be dilated. But however, it doesn't produce bleeding as long as there is no portal hypertension or there's no underlying liver disease. So this is only physiological state. Then certain clotting factors, the procoagulant factors, they are usually increased, and fibrinogen is also elevated. Gallbladder motility is usually reduced. So what happens to gallbladder is, one, because of the progesterone hormone, there's decreased motility, there's decreased contraction, there's increased supersaturation of the bile with cholesterol. So there is a lithogenicity which is increased, which per se translates into gallstones formation. And hence there's increased risk of gallstones. So once there is gallstones, you can have acute cholecystitis. You can be prone to gallstone pancreatitis as well. So these are some of the physiological things which you can see in pregnancy. So this is albumin, globulin, as well as gamma globulins and bilirubin. They are usually reduced. So you have physiological hypoalbuminemia. GGT, the ASTLT, the PTINR, total bile acid usually remains unchanged. So this is important. The total bile acid remains largely unchanged. That is why when it is elevated, you always have a suspicion of intrahepatic cholestasis of pregnancy. What elevates? One is alkaline phosphatase. So that we already know. Alphos has got multiple origins. It's not only from your bone. It's from the liver, from the bone, from the intestine, as well as from the placenta. So because of the placental increase, there is an increase in the alphos. And hence it is not used as a reliable indicator.
Dr. Uma, one person says you're not very audible. Can you just increase the volume and make it a little slow, maybe?
Okay.
You're a little fast. Increase
Is
your
this
volume.
Okay? Am I audible now? Is it okay?
Yeah, better. Maybe you should sit a little closer to the mic.
Okay. Now, how is it now?
Yeah, looks good.
Yeah, okay. Okay, thank you. Fine. So alkaline phosphatase, like we know, it should never be relied on in pregnancy, even if you suspect a cholestatic liver disease, because it has multiple sources from the bone, from the kidney, from the intestine, from the liver, and from the placenta. So your placental alphos per se, it will reflect in your LFT. Lipids, they may be elevated. 5-nucleotidase, 5-HNT, that can also be elevated. However, your GGT is supposed to be unchanged. So that is important when we discuss about cholestasis. AFP, alpha fetoprotein, like you know, in neural tube defects, in those conditions, it may be still elevated. Ceruloplasmin also may be mildly elevated. So these are not very...
Yes, one second, if I mean, like, I will just ask you then and there so that it gets easier for us. Okay. Normally, we don't check bile acids at all in any liver function test. The only time when we check is during pregnancy, when there is a pruritus.
Yes.
Okay. How is it relevant in a non-pregnant women or in early pregnancy? When we do ask for LFT also, they don't do this bile acid.
They don't have to do the bile acid at all. There is no need for doing the bile acid at all unless you suspect an ICP. That is when a patient presents with complaints of pruritus. So other than that, there is no indication at all to do a bile acid. Okay. No need for in any hypertensive disorders or chronic liver disorders. No, in chronic liver, those who have an underlying condition, cholestatic condition, there are two main things. One is a benign recurrent intrahepatic cholestasis, BRIC it's called. And there's something called progressive familial intrahepatic cholestasis, that is PFIC. Okay. So these are the only conditions where bile acids would be elevated. Okay. In an otherwise normal individual. So as such in health, whenever a patient comes to us in OP, we never ask them to do a bile acid at all. Thank you. Thank you. It doesn't help us to arrive at any diagnosis. That's why. So only in pregnancy, when you suspect it could be an ICP, then you need to do a fasting bile acid. Okay, so now this would be the crux of my talk. That is classification of liver diseases which are pregnancy related, the ones on the left side, and non-pregnancy related. So we will be dealing only with the ones which are pregnancy related. However, you all can also ask me questions or you can raise concerns about your non-pregnancy related ones. So what are the physiological things pertaining to liver, what you expect? One is spider angiomas and palmar erythema. So this may be present physiologically in pregnancy, the presence of which should not alarm you to look for any underlying liver disorder. Transaminases, AST, ALT, we already learned, it could be increased little, and the fasting bile acid usually remains unchanged. Indicators of liver disease is when you have a huge hepatomegaly. or if you have a splenomegaly, or even an elevated bilirubin for that matter. So as a rule, any liver disorder in pregnancy usually presents from the third trimester. However, you can have some of them like ICP, which can be early on. Some reports have even shown that as early as 7th or 8th week in pregnancy, it can be obvious. So otherwise, it's usually in your late second or in your third trimester that liver diseases come into play. Hyperemesis gravidarum is something which there is no as such involvement in the liver, but it is a condition where you can have an abnormal liver enzyme. And hence we categorize that as a condition where LFT is abnormal. So that, like you all know, it usually begins at around 4th to 6th week or so. It peaks by around 8th and it comes down by 20th week maximum. By 16th to 20th week, beyond that usually do not diagnose a hyperemesis gravidarum for anyone. So first trimester, hyperemesis. In second trimester, in the late second or third trimester, the other conditions can start.
You mean to say you're calling hyperemesis as a...
No, it's not a pathological condition, but it's where LFT can be abnormal. So when you see an abnormal LFT in a woman who has hyperemesis, anyway, from your side, you'll have ruled out HPSHE and anti-HCV as a part of screening. So there is nothing to worry. You don't have to worry about an underlying liver disorder. That's what I was trying to just bring forth.
Okay.
So hyperemesis, like you know, it's an intractable vomiting leading to dehydration, ketosis, more than 5% weight loss, necessitating a hospitalization, and you'll have followed by correction of the electrolytes as well as hydration status. So 0.3 to 2% of pregnancies can have an HG, and usually but not exclusively begins earlier, but usually disappears by 20th week. So like you know, the beta HCG in the first trimester is responsible for this, and hence it's more common in molar in twin pregnancies. It can result in volume depletion, electrolytes, and acid-base imbalances. Mortality is very rare with hyperemesis. Risk factors, younger age group, obesity, there's increased estrogen has been shown to have some implication in causing this HG. Multiple gestations because of, again, beta HCG may be higher. A history of hyperemesis gravidarum in the past itself can result in this current pregnancy as well. Asian or a black ethnicity, female fetuses. Associated thyroid, parathyroid dysfunction can be a risk factor. Like you know, the beta HCG, it also has got an alpha TSH-like activity. So that suppresses the endogenous TSH, but increases the free T4. The T4 is slightly higher. But however, there may not be any underlying thyrotoxicosis or something. Then hypercholesterolemia, this can also be a risk factor. The presence of type 1 DM, trisomy 21 and hydrops fetalis, and maternal H. pylori infection. So this is what is from the gastric point of view. A gastroenterologist, they will just be looking at maternal H. pylori infection. The rest of all of it is usually a gynecological thing. So presence of underlying H. pylori infection can sometimes worsen it. So the other things are thyroid hormones, ghrelin and leptin. So these also have a say in causing HG. It often recurs in subsequent pregnancies. So this is a questionnaire which is being used. It's called the Puke questionnaire. So pregnancy unique quantification of MSS and nausea. You ask the patient to categorize into what category they fall, and there's a total score out here. So if there's only mild nausea, vomiting, it's only less than 6, moderate 7 to 12, and severe if it is more than 13. So this is only for assessment of how the patient is responding to your medical management. So these are the patterns of LFT, what you find usually and across conditions where liver involvement is present in pregnancy. So first one is ICP. In intrahepatic cholestasis, pattern of LFT would be there have been increase in alkaline phosphatase and total bile acid. So this is very particular because you have an increased bile acid only in ICP and not in pre-eclampsia, HELLP, AFLP, or in hyperemesis gravidarum. So you have a patient coming to you with intense pruritus, especially in the palms and soles. The first thing you have to rule out is ICP, and that is increased bile acid we have to look for in the fasting state. Bilirubin will, however, be normal. How does it differ from pre-eclampsia? In pre-eclampsia with hepatic impairment, you'll have an increased ALT. It can be even 2 to 5-fold or even much more than that. Bilirubin is usually normal, but again, if you have HELLP syndrome, you'll have elevation of bilirubin as well. It's about 1.5 to 10 times upper limit of normal. In AFLP, everything will go on. increase ALT as well as increase bilirubin, but bile acids, characteristically, it is normal. Hyperemesis gravidarum, it's only a mild transaminasis, that is ALT elevation, but usually the bile acid, bilirubin, more or less be normal. So this.
How do you differentiate between HELLP syndrome and acute fatty liver of pregnancy? Clinically, like, can we diagnose? Gynecologists, obstetricians will be able to diagnose?
Yes, definitely you can diagnose. Even in HELLP syndrome and AFLP also, one is HELLP syndrome. Okay, you might be keeping the patient on a watch because she might already be a pre-eclamptic patient. And suddenly now she has come with severe abdominal pain or chest pain, associated nausea, vomiting, headache, blurring of vision. So in these patients also, here you can just look at the parameters on the right side. It's more or less the same.
Yeah, that's what.
Yeah, it's more or less the same, but some things like uric acid. Uric acid particularly, it will be elevated in a patient more with AFLP. An AFLP patient will have more of hypoglycemia and they'll have hyperammonemia. So they may be often confused looking. They'll have slight confusion. They may complain of mild vaginal bleeding and decreased fetal movements in a patient with AFLP. But fortunately, more than differentiating them, all of them, everything finally boils down to just fetal-maternal outcome. So whatever be the condition, we are just managing it. So you have a patient with AFLP, you can have multi-system involvement. For example, even pulmonary fat embolus or even MI. These are all rare instances where AFLP, which can happen. There also, you're just giving a supportive management. So infection is the first thing you have to screen. Second, blood products. If at all necessary, you have to transfuse them sufficiently. Because even HELLP syndrome also, in a small percentage, there is a risk of thrombotic angiopathy post-delivery. So it's not only in prior to delivery, but in some patients, even post-delivery, they can have. So fortunately, you don't have to differentiate also among all of them. All that we need to bother about is, are we supporting all the organs which have been affected? Wherever mechanical ventilation is required, that has to be given. Dialysis, if at all, is required because of rising creatinine, that also has to be done. Infections, as seen by your raised total count, that has to be looked into. And finally, of course, your transfusion of blood and blood products. So that is what is most important. However, we also have to keep in mind the complications. Complications of both of them are hepatic hematoma, a hepatic rupture or infarct, and intrahepatic hemorrhage. So these are infarct, a hemorrhage, a hematoma, and rupture. These are the dangerous things. These are the complications of both HELLP as well as AFLP. That has to be kept in mind. So what are the clinical and biochemical findings in a patient with, classically it occurs before 9th, but this is about hyperemesis. So classically, it's seen before the 9 weeks of gestation itself. Abnormal LFT may be seen, and there may be associated increased amylase or lipase, but usually it's not more than 3 times the upper limit of normal. And a patient with hyperemesis, they usually do not complain of a typical pancreatic pain. So you don't have to worry that amylase and lipase is because of pancreatitis. Most striking feature in some patients with some patients is increased aminotransferases in ICP. This can even be as high as 1,000. So that's why it's darkened over there, because this 1,000 units per liter, units, you do not usually get in a patient with ICP. Usually it is seen in patients with viral hepatitis, or you have in Budd-Chiari syndrome, or any ischemic hepatitis or toxin-induced. But in a patient with ICP also, sometimes you can have OTPT to the level of 1,000 units per liter. Hyperbilirubinemia is generally not seen, it rarely exceeds 4, and it's fully reversible also post-delivery. So increase in aminotransferases return to normal with the correction of dehydration and resolution of symptoms. So increased TSH, usually a marker of disease severity, resolves with treatment of HG itself. Clinical hyperthyroidism, we saw, it's really rare. Thiamine deficiency may occur sometimes. The ultrasound may be necessary also to rule out any other underlying liver problem as well. Like, for example, if you have a biliary obstruction, there also you can have an OTPT to the level of 1,000. So whenever you have an abnormal LFT in a patient, in a pregnant woman, always do an ultrasound abdomen to see if there is any liver pathology. So which means if there's any dilatation of the intrahepatic biliary radicals, or even the CBD, difference in the echoes or steatosis of the liver, that is fatty infiltration. So always the basic is do an ultrasound abdomen. And of course, from the gynec point of view, multiple gestation and high density-form mole, that anyway you all will be doing. Now, what are the maternal and fetal complications? So fetal complications, low pregnancy, weight gain, less than 7 kgs, then low birth weight, small for gestational age, preterm delivery, and poor 5-minute Apgar score. Whereas, what are the maternal complications? Main thing, weight loss. We already saw more than 5% of the pre-pregnancy weight loss would be there. Dehydration, micronutrient deficiency. These are some of the rare complications. Malarial tear. Why does it happen? Because of repeated retching. So as they keep retching, they might have a small linear tear in the lower part of the esophagus, which is called as a malarial. And this is nothing worrisome. You can as well manage it only with your sucralfate antacids. Then vernix encephalopathy. That's why we give thiamine as a treatment for this. Retinal hemorrhages and spontaneous pneumomediastinus. These are all lower down in the list. It's only last thing. Main thing is weight loss, electrolytes, dehydration, micronutrients. So what is the treatment of this? IV dehydration, correction of sodium and potassium. If you think your patient might require long-term hospitalization or even long-term bedridden, then you might have to go for a thromboprophylaxis. Thiamine supplementation in order to prevent vernix encephalopathy. Antiemetics may be given. Mainly it is phenothiazines, that is chlorpromazine and prochlorperazine. These are the ones which have been tried. And dopamine also, metoclopramide, IV, we usually give perinorm, that one. Slow introduction of oral fluids and hydrates is always suggested. Okay. And for nausea, vomiting, vitamin B6, that's your doxylamine, plus pyridoxine also is safe. Only in refractory cases, you might require sometimes ondansetron 1 and glucocorticoids. So generally, it's a usual supplementation itself. The most important thing out here is just rule out an underlying other liver disease whenever you see an abnormal LFT. Next is ICP. So the commonest pregnancy-specific disease is ICP. It is reversible with delivery, but it can recur with subsequent pregnancies. So it's usually characterized by pruritus, intense pruritus of the palms and the soles. And if you do, this is where you have to stress on bile acids. So fasting as well as your postprandial bile acids would be elevated. And they have spontaneous relief of signs and symptoms within 6 weeks of delivery itself, but only to recur in subsequent pregnancies. So there is a variable incidence, 0.02 to 2.4%. 70% they present in the 3rd trimester, but we have some cases which have come as early as 7 weeks as well. More commonly in multiple pregnancy and those who have received any fertility treatment. So in this population, it's more commonly present. Pathophysiology, it's mainly because of abnormal biliary transport across the canalicular membrane. And estrogen also peaks. So if you have multiple pregnancy, you'll have higher estrogen levels if you have twin pregnancies as well as in the late pregnancies. So that is why this increased estrogen is also said to be a risk factor or a cause for ICP. It has got a complex etiology. So some studies, especially there were some books, some studies which said that in some countries like Scandinavian countries and Chile, over there, because of increased cold during the winter seasons, there was increased ICP cases. So some environmental factors, like one is cold, second is selenium content. So that was also known to be a risk factor for ICP in genetically susceptible women. And there is increased risk of development of gallstones, cholecystitis, and pancreatitis. And hence, they say usually these people who have ICP, they do not have an underlying liver disease. They may not even go on to develop any liver disease post-pregnancy. But gallstones, and because of gallstones, a cholecystitis or gallstone pancreatitis, this is quite possible. And hence, the risk of recurrence with subsequent pregnancies is increased with interval cholecystectomy, they say. So there is a recurrence with subsequent pregnancies, in fact, which is increased even if you do a cholecystectomy in between. So these are just some of the studies which have shown. 60 to 70% of the affected individuals develop cholestasis during subsequent pregnancies or with the use of OCPs. So OCPs, they have estrogen. So whenever there is increased estrogen, definitely you can expect an ICP as well. So what are the risk factors? A history in earlier pregnancy, a positive family history of pruritus with OCP use, that is again estrogen, family history, and this mutation ABC4. So this is something which we have to know. ABC4 gene is responsible for MDR3 protein. So what this actually does is it helps in the transport of phospholipids. So phospholipid flippase, that is flipping from one side to another. Okay, so that is important for micelle formation for fat absorption. So when this does not occur, the patients are devoid of fat and fat-soluble vitamins. They can end up sometimes even steatoria. So that's why patients with ICP, they can also end up in steatoria. It's because of this mutation in the ABC4 or the MDR3. Then ABC11 and BSP gene. So this is all from the hepatologist point of view. I'm not sure if it's really important for you all. Yeah, so this is how, okay. So pruritus usually begins from this 25th, that's the second trimester late up to the 32nd week, but occasionally even earlier than that also. But main thing is we have to rule out if the patient is having intense pruritus, you do a bile acids, it is elevated. This could also be unmasking of an underlying liver disease. That is one thing. So whenever the patient has consistent pruritus, even after delivery and after 6 weeks post-delivery, we have to rule out other liver conditions like a primary biliary cirrhosis or a primary sclerosing cholangitis. So these are two other cholestatic conditions of the liver, except other than ICP. So this can affect any part of the body, but predominant in the palms and soles. It's worse at night and disturbs sleep as well. Rash is rare, but may be related to the excoriation because of repeated itching. Occasionally, it's complicated by steatoria. So the steatoria is because of fat and fat-soluble vitamin deficiency. Jaundice usually develops sometimes in about 1 to 4 weeks later. The patient may also complain of high-colored urine and yellowish discoloration of his eyes. So what are the lab findings? Transaminases may be there. It's very non-specific. But bile acids, when fasting and postprandial bile acid is increased, always rule out the presence of an ICP. Risk of complication in pregnancy.
Dr. Mahalakshmi, you are talking about fasting and postprandial bile acids. We generally don't differentiate, because we didn't have any idea about it. What significant is that, fasting and postprandial bile acid?
No, you can even, usually they say fasting is more sensitive because if there is a positive correlation, if it's a false positive elevation post-food, so just to avoid that, we're asking them to do a fasting bile acid. That's
So
all.
a fasting one is a better one.
Fasting one would be better.
Okay.
And risk of complication in pregnancy rises with rising bile acid. So that anyway, you all will be knowing. Above 10 itself, you have to think first itself ICP. If it goes above 40, it has a significant complication. If it goes above 100, then definitely imminent delivery is important. So increased bilirubin is usually unusual. It should prompt investigations for alternate diagnosis. So whenever we have a patient with abnormal LFT, we have a set of tests. What we do, we usually rule out hepatitis A to E, all of it, because we saw OTPT can be elevated in any of these conditions. Because the management of ICP is much more easier. Whereas if a patient has an underlying hepatitis, you have to look for any coagulopathy. They might go in for any failure like encephalopathy, PTINR, all that. But these kind of complications do not happen in a patient with ICP. Because ICP, all that you have to see is just monitor the bile acids and prompt delivery when you have to terminate. That's all. And within 6 weeks, they are good. But rule out the underlying other liver diseases. So increased ALP and 5-NT that we already saw. Increased alkaline phosphatase you cannot rely on because it can be from the placenta. GGT is normal or maybe modestly elevated, being cholestasis. PT is usually normal. See, prothrombin time is usually normal because there is no acute liver injury out here. It's only a secondary to the intrahepatic cholestasis of pregnancy. Increased prothrombin time due to vitamin K deficiency, due to cholestasis, or the use of bile acid sequestrants rather than the liver dysfunction. So ultrasound, first thing we do, because we want to rule out if there's any biliary ducts which are dilated, and we want to see a normal parenchyma also of the liver. That's why we do an ultrasound. Liver biopsy generally is not at all required unless you have any compelling indication. So even if you do a biopsy, what supports this is an ICP is only a bland cholestasis, predominantly in zone 3. So zone 1, zone 2, zone 3, there are 3 zones like this that we don't have to really know now, but it's from the pathologist's point of view. But main thing is just a bland cholestasis. There won't be any hepatocellular necrosis or inflammation. This is what is important. None or minimal hepatocellular inflammation. It's only a cholestasis. ICP is associated with increased risk of hepatobiliary diseases like hepatitis C, cirrhosis, and gallstones. So gallstones we already saw. There's increased risk of gallstones, gallstone pancreatitis, and acute cholecystitis. ICP is also shown to be a close correlate for hepatitis C. And patients with cirrhosis also, if at all they become pregnant, they can develop ICP. Underlying CLD, hepatitis C, or any chronic disease is associated with increased risk of ICP.
Dr. Uma, ICP, you haven't told us, what value is critical? When should we intervene?
Yes, ma'am. This is
There are
the
different
slide.
opinions again in our in guidelines.
Yes, madam. This is
Do you
the
have, as a gastroenterologist, would you suggest some upper limit where we have to intervene?
okay. Now this is the ICP severity: mild, moderate, and severe. So mild is if it is above 10 to 40. So moderate is 40 to 99, and severe is if it's more than 100. So usually if a patient comes, because all of us are looking for just a fetal-maternal outcome, that's all. So if your patient comes post 37 weeks and if she has severe, that is more than 100, you can very well say that, okay, you're good to go. They can terminate pregnancy. But we also learned that ICP can come as early as your first trimester, the end of your first trimester itself you can have. So in such a patient, you do not have to always go by this bile acid. If the fetal heart rate is good, you're able to, their mother is able to perceive it also, the movements, by the second trimester. And if there is no worsening of LFT, I think we can still wait until she completes 36 weeks. So there is no hard and fast rule like that. But however, you have to warn the mother that they stand a chance of these complications. That is, it could be a premature birth, it could be a stillbirth, it could be fetal hypoxia, distress, or meconium aspiration, the ones which I mentioned here. So there is no hard and fast rule, but always keep the patient on your follow-up if she's worsening, which means from mild to moderate, moderate to severe, she's going on. Then, because as of now, even I have one patient who is having a very critical level. She has 250. So it's above all of this. But she's only in her 17th or 18th week of gestation. The thing is that we really don't know if it's only ICP which is present, or like we learned those mutations, this ABC, MDR3. So she might even fit into one of those categories called benign recurrent intrahepatic cholestasis. So even if you have a very high value also, we don't have to immediately terminate the pregnancy as long as the mother and fetus are good. Just keep them on guard. They have to be careful about it. Whenever they perceive decrease any fetal movements, or when you assess the heart rate and that goes below the threshold, then you can take a call. Rather than that, because she's also a primary gravida, it's quite sensitive issue for them to just terminate pregnancy as such when there is no need to. So just keep the patient on guard, but they should be informed about this. That's what I would suggest. I don't know how your take is on this. But of course, ruling out other conditions is very important. Just don't go by ICP only by seeing the fasting bile acids alone. Yes, in fasting bile acids are elevated, mostly it's ICP. But other conditions like hepatitis A to E, all the hepatitis, autoimmune hepatitis, Wilson's disease, even your primary sclerosing cholangitis and primary biliary cirrhosis. So these are some of the conditions where you can have cholestasis. So that also has to be ruled out. That's all. How you manage ICP, just like you manage any cholestasis, UDCA, ursodeoxycholic acid. So they have to be given at an appropriate dose. We see prescriptions which are grossly underdosed, because 13 to 50 milligram per kg is the minimum dose. Okay, so you cannot start just 150 mg BD. It begins with 150 mg in the market, but that's 300 mg is nothing for a pregnant woman. So we always have to go weight based, 13 to 50 milligram per kg. And how does it help? The biliary transport of bile acids. This helps. This is how it enhances. And it is anti-apoptotic, which is it prevents the cholangitis, the cholangiocytes from dying off because of the bile acids toxicity. Improves excretion of the pruritogens or the progesterone sulfates. It enhances the transplacental transport of bile acids from the fetus to the mother and reduces placental damage. Okay, so all of this is how UDC actually helps. UDC has a supportive role, but however, we just have to, even if you start the patient on UDC also, keep the patient on follow-up, ask him to repeat LFT, just to assess if the OTPT is improving or not.
Is there any risk of coagulation problem in ICP?
There is no risk of coagulation problem unless the patient has an underlying chronic liver disease, because the clotting factors are affected only if the patient has an underlying CLD of any other cause. For example, even if hepatitis B, C, or CLD, chronic liver disease because of an alcohol or a non-alcoholic or autoimmune hepatitis, anywhere where per se the liver is involved, that is where the clotting factors are affected. Otherwise, there is no acute condition. This is only secondary to a pregnancy and it just disappears with pregnancy. That's all. So there is no clotting factor abnormality happening here.
How long do this UDCA have to be given? And how frequently do you have to monitor this bile acid?
Bile acid, I usually do not monitor. I only monitor the LFT. So if the LFT is improving itself, the bile acids quite naturally they'll improve. they will show a decreasing trend, or at least there won't be any worsening.
If LFT also, how often do you have?
Once in 2 weeks.
Once
Once in 2
2
weeks,
weeks
yeah,
only.
once in 2 weeks. But
And
if the patient has any symptoms, any worsening she feels, like nausea, she's having an abdominal pain, she's having a loss of appetite, decreased fetal movements, or anything of that sort, then ask him to come removed immediately. Don't go only by the LFT. That's it.
Okay. Then how long do we this UDCA? Do we, like, once we start, can we stop once the bile acids come to normal or the
Yeah,
symptoms
once the
disappear?
LFT comes to normal, you can stop it. Once your LFT and bile acids have improved, you can stop it. But then you don't have to continue it. But again, you have to keep LFT on monitor.
Okay. What are the chances for recurrence? Like, say, supposing I see at 28 weeks, it gets okay by 30, 32 weeks. Is there a chance of her getting again in the pregnancy, say, in the later weeks?
No, not much really, but in subsequent pregnancies, she can. Not maybe in this pregnancy. In this pregnancy, it's taken care of.
Okay.
In subsequent pregnancies, yes, it can. Then dexamethasone, it really doesn't have any role in ICP. It may be given just for the angle of fetal lung maturity. But ICP as such, it doesn't have a great role. So increased risk of hepatic impairment with combined OCPs, but most progesterone containing not associated with hepatic impairment. So it's because of the estrogen component that you have a worsening of any hepatic impairment. Okay. So high recurrence rate in subsequent pregnancies also, what we just saw about it. Obstetric management, planned early delivery after maturation of the fetal lungs. And if there is severe pruritus and the bile acid is more than 40, this is the critical, this is a severe level, moderate level. Mild is, if it's more than 10, more than 40 is moderate, more than 100 is severe. So your patient has got intense pruritus, worsening also of bile acids despite treatment, definitely you have to terminate the pregnancy. Cholestasis of ICP should resolve soon after delivery. Monitor the LFT post-delivery as well, because ICP may not be the only thing. ICP may be unmasking some underlying liver disorder. So that is when you have to monitor the LFT even post-delivery. Until the LFT comes to normal, you have to monitor the patient, even if it's post-delivery also. Prolonged cholestasis is present. Main thing you have to rule out is a primary biliary cirrhosis and a primary sclerosing cholangitis. So these are the two cholestatic conditions which we have to rule out. AFLP, acute fatty liver of pregnancy. So it's a condition with significant maternal as well as fetal mortality if not appropriately intervened. Early diagnosis and intervention is always important. It is a rare complication though. Frankly speaking, I have not seen many patients with AFLP because they have been appropriately managed by the obstetricians itself. But usually it's in the third trimester, like we learned. As a rule of thumb, most of the liver complications, it's in the late second or third trimester. But sometimes AFLP can also expose after delivery, mostly within 30th to 38th week and up to 20% postnatal as well. So like, acute fatty liver. So there is fat in the liver, which means there is steatosis in the liver. So that is how when you do an ultrasound, you can see a lot of fat. When that is present in a woman who has an abnormal LFT in the third trimester, complaining of abdominal pain, always rule out an AFLP of pregnancy. Here you have chance of coagulopathy and encephalopathy. Okay, even in the patient without an underlying liver disease. So ICP will never end you in coagulopathy, encephalopathy, but in an acute fatty liver pregnancy or even HELLP syndrome, you will have an acute liver failure, which means bilirubin is elevated, OTPT is elevated, coagulopathy, encephalopathy can set inside. So like you all know, it's because of the long chain 3-hydroxyacyl coenzyme A dehydrogenase deficiency. Okay, it's a key mitochondrial trifunctional protein. So when the placenta is deficient in this, or the neonates are deficient, then the beta oxidation of L-CHAD doesn't happen, and hence the mother results in AFLP. So if at all you have a child with AFLP also, they may end up in a hyperosmolar ketosis or even an obtundation. And the mother, the father, as well as the child, they have to be screened for this because it can appear in subsequent pregnancies. So this was actually how it began is beginning of AFLP. Steatosis is usually seen in patients who are treated with IV valproate or IV tetracycline. So similar to that, there's something called as a Jamaican vomiting sickness. So that was because of something called ackee fruit. And this is how the origin of this came. So someone who took the ackee fruit, they ended up in AFLP. So then they understood that it's because of the defect of this mitochondrial trifunctional enzyme. Okay. So mothers of neonates with LCAD deficiency, they have 79% chance of AFLP or HELLP syndrome. In fact, there are some conditions, they say about 20 to 50% of the patients with AFLP might be having a coexisting HELLP syndrome as well. So HELLP and AFLP may not separately be present. In many cases of AFLP, you can have associated HELLP as well. So what happens is the fetal fatty acids accumulate. Why? Because the LCHAD is deficient. They return to the mother via the placenta. They deposit in the maternal liver, resulting in liver disease for the mother. So this is more in risk factors are pre-eclampsia associated, multigravidas, multiple gestation, male fetuses, and possibly more in underweight women. So these are some of the risk factors which have been studied. This is the Swansea criteria for diagnosis of acute fatty liver of pregnancy. So if 6 or more of these features in the absence of another etiology should prompt you to make a diagnosis of AFLP, which means the patient has symptoms of abdominal pain, vomiting, polyuria, polydipsia, a transient diabetes insipidus. Okay, that has also been shown to be present in some patients with AFLP. So AFLP can end you in multiple complications. The lung, the heart, the brain, the pituitary, the transient diabetes insipidus, your renal involvement, your liver involvement, you can have DIC, all of these complications. So you name it, an AFLP can produce it. So vomiting, abdominal pain, polyuria, NCAF, bilirubin, hypoglycemia. So this hypoglycemia is important. Hypoglycemia, hyperammonemia, and a confused state for the mother. These are quite common in patients who have AFL. Increased uric acid, increased ammonia, ascites or bright liver. So this bright liver actually is fat. So you ask them to do an ultrasound. If you can see this fat, then you should always think it could be a fatty liver, what you're looking at. Elevated transaminases, renal impairment, coagulopathy, and microvesicular steatosis. So microvesicular steatosis and biopsy is the last thing. We do not expect to do a liver biopsy in a patient with AFLP. Okay. So clinical features, 1 to 2 weeks of anorexia, nausea, vomiting, headache, right hypochondriac or right upper quadrant pain, pruritus, systemic hypertension, edema, because we know it can, many of the cases can coexist with a HELLP syndrome or preeclampsia. Acute liver failure signs, coagulopathy, encephalopathy, ascites, jaundice, and hypoglycemia. Preeclampsia is common but not invariable. So what are the biochemical changes? You look at the labs, your LFT will show increased bilirubin, increased OTPT, prothrombin time is elevated, INR may be elevated, fibrinogen level will be low, platelets will be low, albumin low, okay, it could be even physiological hypoalbuminemia or physiological anemia as well. But when there is a significant decrease, always rule out. Renal dysfunction, renal dysfunction, ketonuria and proteinuria as well. So potential complications are ascites, pleural effusion, acute pancreatitis, respiratory renal failure. Infections, vaginal bleeding or even bleeding from the LSCS wounds. These are also quite common. And the last thing, transient diabetes insipidus. So if at all you have a transient diabetes insipidus, usually desmopressin is given. That is if you have a diabetes insipidus. If that is not there, you don't have to worry at all. So this is the microvesicular fat deposition. Okay. So how this differentiates, biopsy-wise, you can differentiate preeclampsia from AFLP. You'll have a lot of fat. These white globules are actually fat globules. It's by the Congo or oil red O, Sudan O. These are the oil stains that you can visibly see it. But that is, you have to keep everything ready before taking a biopsy itself. All your stains should be ready. Your electron microscope should be ready if you want to diagnose this. And typically what you have out here is zone 3 involvement, microvesicular fatty infiltration predominantly, and only mild portal inflammation. Whereas in a patient with preeclampsia or HELLP, you will have a periportal inflammation that is predominant. Here it's only a mild portal inflammation, but it's a zone 3 or a pericentric around the central veins. That is only if you look deep into the histology of the liver. Around the central veins, you have a pericentric involvement of cholestasis. Close monitoring in ICU, that goes without saying, infusion of blood products, because infection and bleeding, these are the main risk factors how you can lose the patient. So a prompt treatment with antibiotics, transfusion of blood and products, hemodialysis whenever required, mechanical ventilation if you think the heart or lung is at fault, and prompt fetal delivery. Because you're lucky this is only in the 3rd trimester, you don't have to still keep pushing on. Anti-NCEF measures, anti-encephalopathy measures is you have to make sure the patient is not constipated. So rifaximin has to be given, that is a gut absorbable antibiotic, and lactulose enema also. Only then will they keep purging well and their encephalopathy will improve. So 2 to 3 days after delivery, the aminotransferases and NCEF everything will improve. The patients, mostly they improve by 4th week postpartum. Infections and bleeding complications are life-threatening. So liver transplantation only if the patient continues to deteriorate with advancing fulminant hepatic failure. So ideally, you just wait, watch the patient is improving within 4 days. Within 1 to 2 days postpartum, you see there's worsening. That means what? The liver cannot be salvaged. There you might have to go for a liver transplant. So that is always an extreme measure. You always have other temporizing measures prior to that. Monitoring, the mother, father, as well as the child should be tested for the LCHAP. And there's another enzyme also, carnitine palmitoyl transferase. So that is an enzyme apart from this LCAT mutation. Risk of recurrence in subsequent pregnancies, yes. Infants with LCAT, they can have metabolic crisis, a non-ketotic hypoglycemia, and suffer an unexpected death at a few months of age. So they should also be monitored. So it's not everything doesn't just end smoothly with delivery. You have to keep the baby also under monitoring. And you have to do an analysis for the parents as well. Most recover during the first month after delivery, but cholestasis may persist even longer. Histological changes always, it lags behind. It can persist for even up to 2 months. If no underlying chronic liver disease is there, recovery is usually complete, which means all of this is specific to pregnancy. So once pregnancy is terminated, you're good. So this was a prospective study from a tertiary care center in India. This I just got from some article, that's all. AFLP incidence of 30 cases per 1 lakh pregnancies, probably just a high volume center. And PIH-associated liver dysfunction was the most common cause of liver disease in pregnancy so far. So DDs are always an acute viral hepatitis and HSV hepatitis, because herpes simplex is something which affects the liver in immunocompromised individuals. So whenever you have abnormal LFT, first thing, you don't think of only pre-eclampsia or HELLP. Always rule out an acute viral hepatitis, which is much more common in our country than all this. Pre-eclampsia, like it's a multi-system involvement when there is an endothelial dysfunction resulting in target organ damage to the mother. And it can also affect an insufficient placentation. Okay, so endothelial dysfunction where there is an intrasinusoidal fibrin deposition. So this is very important. 2 things. One is you'll have a periportal inflammation and an intrasinusoidal fibrin deposition. Okay, but in the case of AFLP, it's a microvesicular steatosis, which is in the zone 3. This is zone 1. That's all. 3 to 5% of pregnancies, and usually again between 20th week of gestation to 4th week postpartum. I think you all will be knowing this much better. The mother will be proteinuric, edema, hyperreflexia will be present. How do they usually present? Very non-specific abdominal pain, headache, visual disturbances, nausea, vomiting. You might think it's just a viral prodrome what the patient is having. Then when you do a CBC and LFT, that is when you see that the patient is having some transaminases. Complications are liver, the brain, cerebral hemorrhage, as well as the kidney. So the liver is most important because hepatic infarction as well as rupture of the liver. These are impending complications of an unattended pre-eclamptic patient. A progressive renal dysfunction, okay, and cerebral hemorrhage. So progressive renal dysfunction, this can be addressed with hemodialysis, but we do not have any liver dialysis. What we have is a plasma exchange. Okay, and if there's a hepatic rupture, why does this hepatic rupture happen? Because the capsule of the liver is called the Glissen's capsule, which covers the liver. And there is a risk of hematoma formation in these patients. So mild, extravasation of blood from the periportal hemorrhages, they can cause stretching of the liver capsule, eventual rupture. Then what happens? There is a bleed into the peritoneal cavity. So in such a patient, you have to attend to it, involve a hepatic surgeon. They either have to do a hepatic resection, or they'll have to do a portosystemic anastomosis as a temporizing measure, at least until the delivery is over. Okay, hepatic hematoma, this is another complication of this. So hepatic infarct, hematoma, rupture, and intrahepatic bleed. So these are various liver complications. So HELLP syndrome, like it's hemolysis, elevated liver enzymes, and low platelets. So it represents a very severe form of pre-eclampsia, and it's seen in only 0.03 to 0.08% of total pregnancies. But if you take 100 pre-eclamptic patients, you can have 10 ending up in HELLP. So that's a frequency in HELLP in pre-eclamptic patients. 10 to 12% pre-eclampsia, but can also occur in normotensive individuals. So that is important. That's why it's highlighted. And hypertension in about 85% proteinuria is common. It can occur in the absence of hypertension proteinuric. That means a normotensive, which reflecting a multi-system involvement of pre-eclampsia and related disorders. So risk factors are pre-eclampsia, definitely yes. Multiparity, obesity, maternal age, chronic hypertension, diabetes, molar pregnancies, and typically within the late second to third trimester. That is when, and can develop even 1 week postpartum. So HELLP syndrome and AFLP, both of them can also present post-delivery as well. That's what we have to understand. Diagnosis is based on clinical features. Again, you'll have just non-specific or right hypochondriac pain, epigastric pain, nausea, vomiting, blurred vision, bleeding, and jaundice. This is very rare anyway. Significant number of patients may just be asymptomatic. If you just run the blood test for them, they may have an asymptomatic fall in platelets. You may be wondering why the platelets are falling. We've had such cases. Then you have to rule out other conditions like ITP or TTP because they may not be necessarily pre-eclamptic. Then after that only, once you rule out an ITP, TTP, or a cardiolipin antibody, everything, this comes to action. So lab parameters, pre-eclamptic liver involvement, aminotransferases, most of the times it will be 2 to 5 times upper limit of normal, and bilirubin may also be elevated. In HELLP, it's about 10 times upper limit of normal. So pre-eclampsia, usually aminotransferases, say 30 to 40 is your normal aminotransferases. So you say 5 times up to 200 is okay, but not more than that. But HELLP syndrome, you can be massively elevated 30 times, and this will be 10 times upper limit of normal, your bilirubin. That's why your closed DD is always an acute fatty liver of pregnancy. Abdominal imaging is always important. Why? Because liver we have to see, is there any hematoma? Is there any infarct? Is it going for rupture? Imperative in those women who complain of shoulder pain, upper abdominal pain, and hypotension. Okay, so that means there is something happening in the liver. That's why they have the shoulder tip referred pain from the diaphragm. Okay, and to investigate for the life-threatening complications of hepatic hemorrhage, rupture, and infarction, liver biopsy is not indicated. So your tennis classification and the Mississippi classification is famous for HELLP. That is platelets less than 1 lakh, AST more than 70, LDH greater than 600. Even if you see all of this, rule out common things like dengue. There you can have low platelets. There you can have an abnormal LFT. Okay, so rule these things before arriving at a diagnosis of something grave like this. Okay. Infections first, always rule out. Infection, dengue infection, viral infection, then you can set in all this. HELLP syndrome, again, Mississippi classification, I think you all know much better than me. Platelets less than 50, you have up to 1 lakh, less than 1.5 in 3. Pathophysiology, again, it's because of abnormal placentation. So the placental tissue, it releases nitric oxide, prostaglandins, endothelin. Endothelin causes endothelial injury. It can cause intrasinusoidal fibrin deposition and in the blood vessels as well, resulting in macroangiopathic hemolytic anemia, platelet activation, liver dysfunction because of fibrin deposition, we learned, and sinusoidal obstruction. This is what leads to hematoma, capsular tears, and intraperitoneal hemorrhage. So only delivery of the placenta, only treatment is a clinical emergency, and labs usually normalize within 2 weeks, but always keep the patient on follow-up, never forget. Because some of these patients can go on to become even chronically hypertensive. Okay, nifedipine, labetalol, methyl dopa, hydralazine. I think this is all you all know, everything. Magnesium sulfate to prevent maternal seizures. Glucocorticoids, they promote lung maturity if less than 34 weeks. And coagulation support, that is your blood and blood products. Following delivery, maternal features of preeclampsia and HELLP usually resolve within 2 days. So AFLP as well as HELLP, all of them resolve within 2 days. If there's any worsening, you should keep the patient on guard. Neonatal outcome strongly depends on your gestational age and how good the child is to come out. Birth weight is good, the lungs are mature, they'll be fine. Otherwise, with HELLP syndrome, their mortality can be even as high as 7.4 to 34%. The patient results in a hepatic rupture in a mother, 18 to 86%, because you have to involve your hepatic surgeon. They might have to do an hepatectomy. A bleed is imminent. So that is why out of bleed itself, they lose their life. So, but that's all very rare complications. Frankly speaking, I haven't seen any patient with hepatic rupture. Neonatal mortality complications are prematurity and placental insufficiency. So if the baby is very small for gestational age, they're not good enough to be on their own, they result in prematurity, IUGR. Hepatic rupture has a perinatal mortality even about 80%. Yeah, 18 to 80% is your rupture. Okay. And so this is your differential diagnosis. How do you make out the differences? mainly by the prothrombin time may be normal or normal fibrinogen, but if you have AFLP, you'll have everything abnormal. Hypoglycemia, hyperammonemia, creatinine, uric acid may be high, abnormal, prothrombin time, fibrinogen. So that's why when you have a very bad liver, plasmapheresis you can also do. Plasmapheresis or plasma exchange as well. This is only a bridge to liver transplant. So if it's a very bad liver, you might have to go in for a liver transplant itself. Hepatic rupture, hematoma, and infarct. So this usually you suspect everything to the liver is abdominal pain. So abdominal pain, if there's an abdominal distension, the patient goes in for a collapse. Always think there's something happening to the liver over there in a patient who is having a pre-eclampsia. So in contrast to other patients, women with spontaneous hepatic rupture, they tend to be older, they seem to have multiple pregnancies. You do an immediate ultrasound or a CT, you can see blood on paracentesis as well. So whenever you have a hematoma or hepatic infarct like this, angiography with embolization, that's the most important thing, may be effective in controlling any acute bleed anywhere in the body itself. Angiography followed by embolization. So hepatic artery is the one which is bleeding over there. So you have to embolize it. Management must be aggressive, delivery of the fetus, do an angiography, do an embolization, involve a surgeon. Post-operatively, they have a protracted course, but may include in DIC, hepatic failure. Extreme measure is liver transplant, but you cannot always have a liver ready for you. So as a temporizing measure, portosystemic shunt may be created until a donor graft is ready. And a recurrence of hematoma and hepatic rupture has also been reported. So when a mother has come through all of this, definitely you don't motivate them to become pregnant for the second time, because all of this can even recur with subsequent pregnancies. So infarcts, they may also complicate pre-eclampsia. They'll have anemia, leukocytosis, and elevated liver enzymes. Most cases, they develop multi-organ failure, including a liver failure. So that's why all of this culminate to liver failure. And hence, what is important is not diagnosing if this is more than this HELLP or AFLP, everything. Just give supportive care and do what's best at that point of time to make sure the maternal as well as the fetal outcome is okay. This is only for theory purpose. Cross-sectional imaging shows confluent hepatic infarcts when you do an ultrasound. So if you do an ultrasound, you can see if it's a hematoma, if it's multiple infarcts, if it's a bleed or even a rupture. So if you do a paracentesis, you can see blood and necrotic material, periportal hemorrhage and fibrin deposition, which is typical of preeclampsia, will be seen. Hepatic infarction is also quite common if you have any infarct in the body for that matter. Factor V Gladin mutation or antiphospholipid antibody. If this is there, then always remember the patient can go in for hepatic infarct anytime. So these are some of the complications which are specific to the liver. Now, apart from this, there are other conditions also which are not specific to the liver, but can occur in a pregnant woman. For example, hepatitis A to E. All the hepatitis can occur. A, B, C, D, and E. Of this, E is what we already know. It's got the highest mortality. And it's usually seen in Central or South Asia during the monsoon outbreaks. And hence, you do not advise any pregnant woman to travel to Central or South Asia at the time when there is a monsoon outbreak, because hepatitis E in the trimester or any trimester of pregnancy has a very high mortality rate. So travel is best avoided. Otherwise, hepatitis A, you know, how to manage is only just liver enzymes you have to monitor. You give UDCA, you give them liver protectives, that is S-adenosyl methionine. Make sure they eat well and just supportive care. IV fluids, electrolytes have to be taken care of. But B and C, both of them, okay, acute hepatitis B and C is what you all screen for. So if you have a mother who's HPSAG positive, you don't immediately start nucleotide analogs. First, you have to see what is the viral load, because what you are actually preventing is the mother-to-child transmission. And hence, only if the viral load is very high, let us say it's more than 2 lakh, in an HPS and HPE positive, if the viral load is more than 2 lakh, then you start nucleotide analogs, and that too definitely most of you all, I think you will be starting only with the help of a gastro. You start the nucleotide analogs by 28th to 29th week, and then you continue for at least 6 weeks postpartum. Okay, hepatitis C, there is no treatment during pregnancy. None of the medications are safe for the baby. So hepatitis C doesn't cause any acute liver failure also. If the mother is said to be anti-HCV positive, wait until delivery. Unfortunately, we don't even have vaccine also for hepatitis C. But wait until delivery. Thereafter, refer the patient to a gastroenterologist and they will look at the viral load and accordingly start. Hepatitis B, babies always have to be managed with immunoglobulin and vaccine, which has to be given within 48 to 72 hours of birth. That's all. I can take some doubts, if any. I hope this has helped also.
It's a wonderful talk by Dr. Uma. It was very informative and concise. Doubts? How prevalent is other vascular diseases and transplant in patients coming with pregnancy? Any idea?
Vascular diseases means like, ma'am?
Like Budd-Chiari syndrome or something like that is there with pregnancy cases you have seen, and any?
I've not seen any Budd-Chiari cases, but how they differ is, one is because as such pregnancy also they say it's a prothrombotic state because of high estrogen. If they have any underlying cardiolipin antibody or factor V laden mutation or any JAK2 mutation, there is a chance they could have a thrombus. So in these patients also, you have to involve a vascular surgeon, you have to involve a physician, because in acute thrombus, you have to give anticoagulants. How safe they are in pregnancy, that's also very important. And these patients, if they should never have an underlying chronic liver disease, because any patient with underlying chronic liver disease, they will have portal hypertension and esophageal varices. So if you start anticoagulants on them, they will bleed because of the esophageal varices. That is something which we have to look into. And post-transplant patients, usually they say that the first post-transplant year, that is when they're prone to infections. So if they want to become pregnant, let them become pregnant at least in the second post-transplant year. MMF, strictly teratogenic, should never be given. Others, they can just cause hypertension, hyperglycemia, and gingival hyperplasia and all. So that has to be monitored accordingly during pregnancy. But there are very few and rare instances, what reports say, I've never seen, but reports say of graft rejection sometimes in pregnancy.
In cases of hyperemesis, when we suspect jaundice, generally we do urine bile salt bile pigments. If it becomes positive, then we go for LFT. I mean, like general, just to avoid too many investigations.
It's not needed, madam. You can directly go in for LFT. LFT is more specific.
No, what's the role of checking urine bile salt bile pigments?
Okay, actually, I never check for bile salt bile pigment because
you don't check at all.
We never check at all. We directly go in for LFT because how we approach is just LFT, hepatocellular, cholestatic. That's all. So hepatocellular means A, B, C, D, E. These are viruses you have to rule out. If it's cholestatic, we have to rule out other cholestatic conditions. So bile salt bile pigment can be positive in hepatocellular conditions. It may be positive in cholestatic conditions, very non-specific. It's mainly by looking at the OTPT. There you can go to pregnancy.
Metabolic disorder.
Participants, are there any doubts? Please.
If there is a fatty liver for the patient, a quite obese patient becoming pregnant, anything to be taken care of during pregnancy?
Nothing, madam, but fatty liver is usually because of metabolic dysfunction associated with they are prone to develop diabetes, GDM. They can become PIH. So these kind of dyslipidemia, these kind of complications, hypothyroidism, that they may be there. They perfectly fit into the metabolic syndrome. So hypertension, hyperglycemia, diabetes, dysthyroid, all of this has to be ruled out.
Thank you. Thank you, Dr. Uma.
Thank you. Thank you. Thank you so much for having me.
Sahiti, we can wind up. You can thank and then